Good. So this will probably go around 45 minutes or so, maybe a little bit longer, depends obviously how fast I go. Um, but for those of you who have studied some arthritis clinically in the bone board and on MSK, this will be a little bit of a refresher. And for those of you who have not, it'll be hopefully a good foundation. And it basically focuses more on the radiographic assessment of arthritis, the plain X-ray assessment of arthritis, as opposed to advanced imaging, because the plain X-ray is still the basic unit of initial assessment. So let me just see why it's not really wanting to advance here. There we go. So here's the outline. We'll talk about basic features of arthritis, and then we'll go into different subtypes, osteoarthritis, the inflammatory arthropathies, crystal diseases, and a little bit about connective tissue diseases at the end. I do want to thank Dr. Stevens, who gave me a number of the images that I put in this updated talk, and my colleague Henry Jones, who many of the older images are from Dr. Jones's collection. So if we talk about basic features of arthritis, these are the categories that I like to think of. You want to look at the soft tissues, you want to look at the joint spaces, the bone, the alignment, and the distribution of the arthritis within the skeleton. In terms of the soft tissues, you want to look and see if there's actual swelling involved, whether that might indicate soft tissue swelling itself or a joint effusion. You want to look at the density of that soft tissue swelling because it may be calcified or not. And joint space evaluation, whether this joint space is lost in a symmetric, kind of uniform way across the joint or asymmetrically within a joint, is important. Is there fusion of bones? You want to look at the bones for their density, obviously for erosions and periosteal reaction in certain disorders. Secondary phenomena like cysts or sclerosis, whiteness in the bone, joint alignment, and then really the key probably to understanding arthropathies or diagnosing them and getting a good differential is the skeletal distribution. Is it something that involves one joint or multiple joints, and does it tend to involve large joints or small joints or both? And then certain arthropathies will involve specific joints and or spare specific joints, and that's really helpful for your differential diagnosis. And so we'll go through many of those things as we go through cases. This is kind of a handy little simple table, if you will, that basically divides arthritis in general into whether it involves just one joint, monoarticular, or multiple joints, and then whether it's erosive or non-erosive. And probably the most important thing, if you take away one thing from this whole talk, is that if you see something that's involving primarily one joint, and if it looks like it's erosive, then you really have to think about a septic arthritis. And we don't want to miss that because infection can destroy a joint and the cartilage within a joint very quickly and lead to all kinds of problems down the road. So you definitely don't want to miss a septic joint. The most common cause of monoarticular involvement, one joint that's not erosive, is like if you injure a joint. Like this is common in the ankle, chronically twisted ankles leading to post-traumatic osteoarthritis. But many of the things involve multiple joints, so they're polyarticular. And definitely the things that are systemic diseases like rheumatoid arthritis or psoriatic, the inflammatory arthropathies are systemic disorders, so they will involve multiple joints, as does something like gout, crystal disease. And osteoarthritis also involves multiple joints, but that's a non-erosive type of arthritis. So let's just take a quick look at this case and see if you see anything abnormal here. A 49-year-old woman with left hip pain came into the emergency room. Turns out these radiographs are pretty much negative, right? The hip joint spaces are preserved bilaterally. We don't, in adults, we can't really detect joint effusions in the hip as you can in kids sometimes. So this looked pretty unremarkable. She ended up undergoing an MRI scan, as shown here. So here's axial T1 and T2 with fat suppression. And we're seeing a large joint effusion in the left hip. Normal in the hip is just a small trace of this white signal, joint fluid. So this is a considerable effusion, and there's also some signal abnormality involving adjacent muscles. So this is concerning, right? With acute onset of hip pain in a otherwise healthy patient, a hip effusion needs to be considered concerning for infection, for one thing. It could be inflammatory or it could be related to an injury. She didn't have any particular injury. So things to consider: large effusion, soft tissue edema. You might consider an inflammatory arthropathy or possibly injury, like I mentioned, or infections, the number one thing. And the key thing about this is just not to miss joint infections, okay? So what we do in these patients, especially in the native hip, it's an emergency. We will take them to fluoroscopy and aspirate fluid from the joint and get that cultured and gram stained for treatment, because the emergent treatment for a native joint is to go and have operative decompression. So in this patient, we tapped the joint and got about 10 cc's of fluid, and it turned out to be a streptococcal joint infection, hip joint infection. And it turned out, looking at more of her history, she had a UTI recently, and it might have been that she had a little bit of seeding of the bloodstream and got involved a hip infection that way. Okay, so the key thing is not to miss that, because if you do miss it and the patient goes on to have a septic joint, you can lose the articular cartilage. Like on this side, you can get erosive changes involving the bone on both sides, and basically lead to destruction of the joint in such a way that they probably end up needing to get a joint arthroplasty done once the infection is settled down. So don't miss a septic joint. Again, here's one where there's osteolytic change about the left hip. The right hip here is normal. You see the cortex of the femoral head. You see the joint space here. But on this side, you can't really see that very well at all. So that's one that was, I don't know if it's really missed, but it's kind of advanced infection involving the left hip. So let's talk about osteoarthritis. And this is a thing we see every day, all day long on the bone board, it seems like. And it tends to be an asymmetrical distribution within joints. And what that means is, like for larger joints, it doesn't involve the cartilage concentrically or uniformly. Like in the hip, you get superior migration of the femoral head, because it's basically, you think of cartilage degeneration and then cartilage loss. That's not necessarily a uniform thing throughout the joint, which makes it different in many ways than something like rheumatoid arthritis. Common to involve the hands, CMC joints, DIP joints, and PIP joints, and the feet as well. Hips and knees, we see a lot of that, and I'll show you some examples in just a moment. So in smaller joints, though, the joint space narrowing can be somewhat symmetric. In other words, like a PIP or a DIP joint of the hand, the cartilage kind of wears out fairly uniformly, so you'll get what's called symmetric joint space narrowing, but it's more asymmetric in the larger joints. You get osteophytes at the margins of the joint. You can get cyst formation on the subchondral bone, and then sclerotic changes, so whiteness where there's more bone being laid down. Now, I have a number of these pictures in here that are from a really nice review article that was just from last year in Radiologic Clinics of North America. And this is available through the Lane Library if you want to download that reference. And it's nice because it gives the diagram or picture of the hand and shows the target areas for these different types of arthritis. So OA, first CMC joint of the thumb, IP joint, MCP joints, doesn't necessarily spare the other ones, but it definitely can involve the MCP joints, and then showing the DIP joints here. So if we look at some examples, we're looking for the hallmark features of OA, which include narrowing of the joint space, osteophyte formation, and subchondral sclerosis. And so this is mainly involving the PIP and DIP joints here. I don't know if I zoom in on this one here or not, but not really. But you can see in this right third DIP joint that there's narrowing of the joint compared to the neighboring joints. There's narrowing here, and there's a little bit of osteophyte formation in some of these joints here. So this is a pretty typical appearance for OA involving PIP and DIP joints. You can get not only the degenerative changes of OA, where the joints narrowed, osteophyte formation, and some sclerosis, but they can form cystic lesions about joints in the fingers. So this is so-called mucus cyst. It's just basically a pocket of thick fluid that's adjacent to the joint from the arthritis. Classic appearance of osteoarthritis involving the hip joint here, where the cartilage space that should be here is really narrowed, completely gone, in fact. There's still some space medially here, so it's asymmetrically narrowing superiorly. You have osteophyte formation, little areas of lucency that represent cysts, and some sclerosis as well. The shoulder is not really a primary site for osteoarthritis, but if you have a disorder, like if maybe you have a chronic rotator cuff tear and some instability or prior trauma or prior inflammatory arthropathy, then you can get an osteoarthritis look in the shoulder joint where there's joint space narrowing, sclerosis, and osteophyte formation. The cyst formation can be large, and so here in this patient, they have a fairly normal right hip, but the left hip shows narrowing in the superior cartilage space here, or joint space, and this lucent area in the acetabulum represents a large like subchondral cyst or geode, and that's basically where the fluid from the joint kind of percolates through little perforations into the bone and creates a cystic lesion over time. They're benign, they're not necessarily a problem in and of themselves unless an arthroplasty is going to be done and they kind of have lost some bone here and they may not be able to get a good anchoring of screws in this area, or they may need to fill it in order to get a good purchase for the arthroplasty. Some patients are a setup for osteoarthritis, like this patient had developmental dysplasia of the hip, so they were partially uncovered, and this is a woman, she has terrible osteoarthritis both sides, like the femoral heads are actually kind of flattened, and the acetabulum is steep. That's part of the DDH probably, but the OA is the loss of joint space, large osteophytes, and sclerosis. Now, in younger patients, like if you see osteoarthritis, you might think of a prior insult. Like this is a 41-year-old, so a fairly young man with degenerative joint disease, and he probably had femoroacetabular impingement, which was a setup for this arthritis that he got. So you can see the left side is a little bit more normal than the right side, but the right side you can see narrowing of the joint. You see these projections off the femoral head neck junction here. Those are the osteophytes. And so this is like a moderate amount of osteoarthritis in a man that's probably not, typically going to be getting this amount of arthritis until you're in your 60s, 70s, if it's just like routine OA. So in that particular patient, he underwent resurfacing arthroplasty, so had to have that surgery done early in life, which is not a great deal because he's likely to outlive these prostheses. The knee is also a very common spot for osteoarthritis, and we see this all the time, every day, and it's just basically looking for narrowing in the lateral or medial tibiofemoral compartment, patellofemoral compartment with osteophyte formation. May or may not have joint effusions. It's classically taught that osteoarthritis does not have inflammatory components or joint effusions, but it's probably becoming more realized that OA can have an inflammatory component, so it's not necessarily wrong to inject these patients with corticosteroids and treat that inflammatory component. But it's not the primary mechanism that occurs in things like rheumatoid or psoriatic arthritis. Those are primarily inflammatory arthropathies. So if the cartilage breaks off in a joint, you have these little bits of cartilage that come off the osteoarthritic areas, and that can then float around in the joint, leading to joint bodies, sometimes called loose bodies. I would not usually call them loose bodies because you don't always know that they're loose, but they're in the joint and they can migrate around. So in this patient, they migrated from the main joint space around the knee into the back of the knee, into a popliteal cyst, so into like a Baker cyst. And the reason these are so large is because the cartilage is like nourished by the synovial fluid. And so still surrounded by synovial fluid, the cartilage can then grow over time and then calcify over time. So these can get huge. They obviously didn't come off the joint surface this big, but they grow over time in the joint. An example from Ken Buckwalter from the literature about like a huge geode. So you can see if you have a perforation in the bone here, fluid can percolate in and gradually kind of take away bone. It can look like it could be an aggressive process, but it's good to realize that if you deal with lesions like around joints, you always kind of be thinking, oh, could this lesion, maybe I'm worried about a tumor, just be related to an arthropathy, in this case, just osteoarthritis. We see a fair amount of OA in the ankle, and so here's like a patient who had multiple prior ankle sprains. They've got malalignment, they've got severe narrowing over here, still some soft tissue swelling, some osteophytes. Hallux rigidus in the great toe, so here's big osteophytes dorsally, and narrowing of the joint, but without hallux valgus. So this is more of a straight toe, and it's stiff, thus the term hallux rigidus. Now, you can have a more erosive type of osteoarthritis that occurs in the hands, and the classic thing for that is to talk about this sort of seagull appearance, because what happens is you get erosion kind of centrally in the joint like this. So you can see how it looks like the wings of a seagull here, drawn by Dr. Stevens, our resident artist there. So there's that little seagull thing. And this can get fairly advanced. I mean, it can look really pretty nasty. This is an older case from Dr. Jones's collection, where if we zoom in on this second DIP joint, you can see how severely eroded and soft tissue swelling adjacent to that. A lot of damage in this, like this fourth PIP joint. So for this, you wouldn't be able to know for sure that this is just, oh, you can't just say, oh, that's erosive OA. You'd have a differential diagnosis for that. And for something like this, just one joint, you might think about something like infection. If you have multiple joints involved, then something even like psoriatic arthritis or an inflammatory arthritis could give you this type of an appearance. Okay. Now, so OA also involves the spine, and we'll talk more about spine and different conferences in the context of disc disease and nerve impingements and things. But in the spine, you get disc space narrowing, osteophytes, sclerosis, a lot of the same features, a lot of facet joint osteoarthritic change, and then the malalignments that come with it. So it's probably, I don't know if it's billions or trillions of dollars of healthcare dollars go into our bad backs collectively, right? So, lumbar spine degenerative change with osteophytes, narrowing, sclerosis. Welcome to the bone board. Okay. So let's talk now about the inflammatory arthropathies. So this is an important category because so OA is non-inflammatory in general. Then you have the inflammatory things, which are systemic diseases. And one thing that I guess that's helpful about that is in some of these are symmetric, and it kind of makes sense that something that's like a systemic disease is more likely to be, symmetric in the body than something that's more kind of randomly occurring, such as osteoarthritis. So rheumatoid, this is the kind of prototype, most common type of inflammatory arthropathy that we see, and this tends to be bilateral and symmetric. So if people get hand and wrist involvement, it's often very symmetric side to side. Whereas if I get osteoarthritis in like my first CMC joint, it's more likely to be on my right hand because that's my hand of more mechanical activity. It can involve wrist, MCP, PIP joints. Probably one of the most important things to take away again from this talk is this rheumatoid spares the DIP joints. So you see our little diagram here, all the wrist joints, MCP joints, PIP joints, but the DIP joints are spared. And so when we look at cases clinically, if you take a quick look at the DIP joints and you decide that they're involved or not involved, that kind of takes you towards rheumatoid or not right away if you're thinking inflammatory arthropathy. So that's a really helpful thing. And the same thing is true for the feet. You get a lot of different involvement, but the DIP joints in the feet tend to be spared. So you get soft tissue swelling because of inflammation and synovial thickening and joint effusion. You can get osteopenia from increased blood flow to the area. And you get these things called marginal erosions, okay? Ultimately, that destroys the cartilage throughout the joint, and you get joint space narrowing. You can also get these rheumatoid nodules from rheumatoid arthritis and pannus formation in the soft tissues. So this is from RadSource, and I wanted to show this because it shows these so-called the bare areas. And so here's obviously the bone, like this might be a PIP joint in the hand, and the white's articular cartilage. The joint capsule is shown here as this blue, and then the white is like some just connective tissue. The red is the synovium, and that's a lot thicker on this cartoon than it is normally. Normally it's just a thin layer. But notice what happens is the synovium comes in the joint, and there's an area that's between the capsule and the cartilage that's actually not covered by cartilage here, like all these little red triangles. Those are the so-called bare areas. So then what happens is if you get synovial inflammatory change, it's going to start to eat away at the bone on those margins of the cartilage earlier on than it's going to erode away the cartilage, right? So this is sort of like a high risk area in these so-called bare areas. So this is from Dr. Jones, and this is a progression of disease. It's old cases, but luckily these days arthritis is being treated better, so we don't see people go through what this woman went through, where where she got really bad arthritis over time. Like in the first set of images from like 1974, so we're going to go to like I think 1980 or 6 or 8 years. It progresses a lot. Now here, maybe things look just pretty normal. Maybe there's a little bit of lucency around joints, some periarticular osteopenia. I find that to be a difficult sign to interpret, but maybe there's a little bit more lucency about joints from some increased blood flow. A year later, you can see more soft tissue swelling. If you kind of step back, you can see soft tissue swelling about these PIP joints here and here. And I think I'll zoom in on this in a second, but start to see little irregularities along the margins of the joints here. So here, for example, see if we can find a fairly normal joint. So like this MCP joint here, fairly normal. You see the subchondral cortical bone there. You see the joint space, pretty smooth margins of the bone. But look at this PIP. You start to see these little lucencies here, probably there, a little bit there. And this one has a little bit of a lucency right there. Those are erosions. So these are like erosions here and here and erosion here. So those are fairly early erosions. The joint spaces overall are still fairly preserved, but as this progresses, those joint spaces are going to get decreased because you have the cartilage diffusely wearing out. So again, this is just that diagram of the bare areas showing that this is the at-risk area, and so that's why these areas of the bone and these inflammatory arthritis get involved first. So this is about 6 years after the first exam, and you can see now her hands are severely deformed. There's a lot of loss of joint space in the carpal bones. The carpal bones are shifted. There's a lot of soft tissue swelling. These MCP joints are malaligned. There's extensive erosive changes throughout. And even 1 year later, it shows what used to be done to some extent was to actually do joint prostheses, these little silastic prostheses in the MCP joints to help treat pain. They're doing less of these days because they turned out that people would get inflammatory reaction to these prostheses themselves, or they would break down, and they just didn't really work out that great. So we don't see as many of those currently. But so here's now a patient who went in like 6 or 7 years from fairly normal looking joints to severe joint arthropathy and extensive involvement bilaterally, fairly symmetric in distribution. So we do some MRI to try to detect subtle cases of arthritis. We don't do it as much for staging and kind of monitoring of therapy, although it is used by some folks for that purpose. Here's what you might see if you looked at an MRI in severe rheumatoid arthritis. So here's a T1 weighted image where you see these dark foci within the ulna, radius, and involving carpal bones here that correspond with edema on the T2 weighted images. So these are basically erosions. And then if you give intravenous contrast, everything lights up. All the synovium enhances dramatically. It's kind of soft tissue thickening, and these areas of erosive change and inflammatory change within the bone can also enhance. So it's a good test. It's probably more sensitive than the radiographs, but it's expensive. And usually, the diagnosis of inflammatory arthritis is made on a combination of clinical factors, right? Like they'll have the patient's physical examination, what joints are swollen, what's the timeline, and then rheumatoid factor, SED rate, all kinds of clinical parameters that go into like deciding that patient's got rheumatoid arthritis or not. In larger joints, rheumatoid can really be destructive as well. So here's an elbow. It's hard to even tell that this is an elbow anymore because there's such large areas of erosive change. In the hip, it's not uncommon for us to see kind of a concentric arthropathy where there's more what we call axial migration as opposed to superior migration of the femoral head, which is in OA. So the whole hip tends to move in an axial central direction here as the cartilage is lost. Now, when the cartilage is all gone, then bone on bone is occurring, and then you can start to get some secondary osteoarthritic type changes. You get that sclerosis, and you can get osteophyte. So a lot of patients that we see coming in for their hip replacement, they have a combination of prior inflammatory arthropathy and then secondary OA. And so if you see a case like this where there's severe narrowing of the knee joint spaces, but not that much in the way of osteophyte formation, it's not uncommon for that to be like a rheumatoid arthritis patient. A really important thing in the spine is atlantoaxial instability. So these folks can get C1, 2 pannus formation that can lead to ligamentous laxity. And this doesn't show it. I'll zoom in on this in a second, but I just want to show the flexion, neutral, and extension views here. And it's important when we look at these in whatever scenario, like in subacute trauma or whatever we're doing, want to make sure you see all the way down to C7 and T1 to check the alignment throughout the spine. But this is focused in on the C1-2 area just for illustration purposes. So normally this space between the anterior arch of C1 and the odontoid process of C2 is about 2 millimeters, and it should stay the same whether you're in neutral, flexion, or extension. These green lines show how it's increased, and even just to hammer that home a little bit more, so I outlined the dens here, so C2 and C1 anterior arch. This is about 10 millimeters in flexion, and now it's about 2 millimeters in extension. So this is kind of quite unstable. Really, the patient may or may not have a lot of symptoms from this, but it's critically important if somebody goes to the operating room or gets intubated, they'll pull up on the neck and people can have like devastating complications of spinal cord injury if this isn't recognized. Okay, so you might have to do an awake intubation or a special type of intubation. There's some deformities that occur in arthritis based on either the joint destruction or tendon involvement. And even though I'm showing mostly the radiographs, these inflammatory disorders have tenosynovitis and inflammatory changes within tendons, and then they can actually have tendon ruptures. And so one of the things people can get is this boutonniere deformity here, like this fifth PIP joints in flexion, the DIP joints in extension. And so that's this so-called boutonniere deformity here. And that's a little bit different than this other one called a swan neck deformity. See, in the swan neck, it's kind of like the PIP joints in a little bit of hyperextension, but the DIP joint in flexion. So they get that sort of thing. Another case of an elbow, and this is where you can get these erosions occurring around the margins of the joint, big erosions, narrowing of the joint, and often joint effusion. It's a little bit hard to see in this case, but there's a pretty sizable joint effusion here. Getting almost done with rheumatoid arthritis, it also can involve bursae, and not all bursae have synovial linings, but the ones that do can definitely be affected by rheumatoid arthritis, and it's one of these things that gives this disorder called rice body synovitis from these little beads of tissue that occur within the joint. They look like little grains of rice, right? So here, predominantly in the bursa. Do you know of another disorder, if you had a differential diagnosis of rice body synovitis or bursitis? What's the other classic disorder we want to bring up? TB. Excellent. Okay, very good. This one happened to be rheumatoid. Moving on to psoriasis. Okay, so this is also something we see a fair amount, and it doesn't occur in all patients with psoriasis, but in a small subset. I think it's actually, there's some higher correlation in people that have psoriatic nail involvement. Here's like a typical picture of psoriasis on the extensor aspect of the elbow here. It can actually occur, the arthritis can actually occur before onset of the skin changes. So somebody might show up with an arthritis of unknown cause, and it's not till weeks or months later that they actually get the arthritis showing up to be like, aha, that's actually psoriatic arthritis. It can involve, this one is, as opposed to rheumatoid, even though it's systemic, it kind of scatters around. So it might involve one joint or multiple joints, but it tends to be more likely asymmetric than rheumatoid. And it tends to spare the larger joints as well. So any of these can involve any synovial joint, but this one and reactive arthritis also do more of involvement of the so-called entheses. And the entheses are where ligaments and tendons attach to bone. We'll see examples of that in a moment. So you get inflammatory changes there as well as in the joints. Hands, feet, spine, SI joints. We're going to look at a few SI joints for these different disorders. Okay, so here's psoriasis, and if you remember the picture for rheumatoid, it was basically fairly involvement of the MCP joints and PIP joints. This is a little bit scattered more so, and the big oval here is to indicate this soft tissue swelling, the so-called sausage digit kind of manifestation of psoriasis. And again, another key thing here is psoriasis will involve the DIP joints, whereas rheumatoid will spare those. So that, if you're thinking inflammatory arthropathy, DIP joint involvement, not going to be rheumatoid, could be psoriasis. So there's all these little buzzwords that come up with it. Sausage digit for a diffusely swollen finger. The other thing, the bone density in psoriasis tends to be preserved as opposed to rheumatoid where it gets osteopenic. Get a lot of erosive changes, and the erosions may be larger and more prominent until you get that diffuse joint space narrowing. The other thing about psoriasis, you get proliferative changes of the bone, whether that's periosteal reaction or at these entheses. So here's nail involvement, right? So psoriasis can involve the nails. There's a little bit of the rash as well here. This is a fairly mild degree. I mean, if you want to see advanced pictures, you can go to the web, but I didn't want to have anything to be too nasty during the noon hour here. So bone density tends to be preserved. It can be a little bit scattered around, like I said, but you get this periostitis. So that's something important to look for, and we're going to zoom in on this digit here where you can kind of see some diffuse swelling of that DIP region, maybe this second finger here as well. But you see along the margin of the bone here, see that irregularity? That's some periosteal reaction. And so that's a hallmark feature of psoriatic arthritis. Not everybody gets it, but if you do see that, that really helps make the diagnosis. Here you get swelling, a little bit of erosive change there. More, little bit of periosteal reaction about the great toe here, the IP joint. You have erosive changes, a lot of soft tissue swelling. Sometimes you get this really dense white appearance of the bone. That's the so-called ivory phalanx, right? So this is a little bit whiter than the adjacent bones. It's maybe not the most dramatic example. And so psoriasis is also one of the arthropathies, in fact, maybe one of the only ones in adults that you can get bony fusion. So here's a patient who later on had bad arthritis and then spontaneously went on to fuse. In kids, they can fuse with juvenile chronic arthritis, but in adults, it's very uncommon to fuse. I mean, most of the fusions we'll see in adults are going to be because of surgery, unless they have psoriasis, in which case they can go auto-fuse. The sacroiliac joints are involved in a lot of these, and the spine. And I show this diagram because it helps us understand why when you look at the SI joints here on this axial view, it's more likely to see changes on the iliac side of the bone than on the sacral side. And the reason is the cartilage, this black here, is thicker on the sacral side than on the iliac side. So if you have a process that's eating away cartilage from an arthropathy, it's going to basically eat through the iliac cartilage sooner than the sacral cartilage. So you're going to see erosions on the iliac side first. Later, you'll see them on both sides. So here's psoriatic arthritis. Tends to be bilateral but asymmetric, but it's sometimes hard to tell that it's actually asymmetric. But you're looking at the SI joints, and you want to look at the lower 2/3 here. The upper part of the SI joints is primarily fibrous with ligaments going across, so you don't have as much inflammatory tissue there in the synovium. You don't really have that much synovium. You have synovium in the lower part of the joint. So here you can see some irregularity, some sclerosis. It's not the easiest diagnosis to make, but it's not quite normal, and you'll see cases of this in the reading room as well. Certainly easier on something like CT, and I'll show CT in a minute, or MRI. Sausage digit, so this is why it's called that, right? This looks like a 4th of July hot dog right there, right? And the other digits are fairly normal, but just diffuse soft tissue swelling, joint space narrowing, some erosions, and in this case, maybe a little bit of osteopenia in that digit as well, which is a little bit atypical, but maybe because it's so painful, they're not using it. Another buzzword, pencil in a cup. So this is where you get erosion of the bone in sort of a central way, and then the eroded bone more proximally kind of pokes into it like you're sticking a pencil in a cup. Okay, so that's another thing in psoriasis. So-called mouse ear, or these marginal erosions. Same principle as in rheumatoid, where you get these little erosions. These look like cute little mouse ears, right? Starting in the bare areas of the bone. Now, this one doesn't tend to involve large joints, but it can. And so here's a patient who has a huge joint effusion without a whole lot of other abnormalities, probably some narrowing of the medial compartment, but it's just a big inflammatory effusion, which turned out to be related to psoriasis. The asymmetric sacroiliac involvement, probably the best test to diagnose sacroiliitis is MRI. We don't do a lot of this, but we do some of it, and it's usually kind of a troubleshooting process as opposed to like primary diagnostic tool. But here you can see there's bright signal in the sacrum and some in the iliac side here, asymmetric from the more normal left side, and it can be hard to perceive the erosions, but there's a little bit of irregularity. So this is certainly consistent with sacroiliitis. It's asymmetric in this patient that had psoriatic arthritis. We're using a little bit more ultrasound these days to look for active synovitis in these patients because it can help. A lot of them are put on drugs that are quite expensive and can have quite a bit of side effects. So this is from John Red, who's a radiologist down in Australia that shows a lot of interesting cases on our blog. Patient with swollen PIP joint, some bony irregularity here. And on the ultrasound, these longitudinal ultrasound images, you can see, so this would be the middle phalanx, here's the PIP joint and the proximal phalanx. That irregularity right there, that divot, that's an erosion. And you can see some hyperemia there on the color Doppler showing that there's inflammatory change. Moving on, ankylosing spondylitis. A lot of stuff here, and I'm going to post this. I can also make all these slides available to you as well for review purposes. Tends to affect fairly young males, spine and SI joints. It's not that common for us to see the larger joint involvement, but it can sometimes affect things like the hips and shoulders and knees. Here's a patient with ANKSPOND, and they're basically trying to show that when he extends, maybe he extends okay, here's neutral, but when he flexes, there's really no curvature that develops in the spine because it's so stiff here, all right, in a fairly advanced case. So here you get a lot of fusions, and I mentioned that in psoriasis in connection with the digits, but in ankylosing spondylitis and kind of related disorders, you get a lot of spinal fusion, and so we can't quite see it as well here. I'll show other examples, but you get bad sacroiliitis. It tends to be bilateral and sort of more symmetric than in the other disorders. This is actually showing fusion of the posterior kind of longitudinal ligament area over the spinous processes. Sometimes that's called the so-called dagger sign because it looks like a knife. In the SI joint, so this is normal. So you have like smooth but undulating contours of the SI joints with a little bit of white subchondral bone that's normally visible there. Start to get erosive change on that iliac side. See these little notches out of there? Those are erosions on both sides. And ultimately, if this progresses, that can go on and basically fuse. So on MRI, again, you'll see bone marrow edema, usually on either side of the joint, more so on the iliac side in this case. May or may not see the erosions as well on MRI, depending on the resolution. But ultimately, you may end up going on to something like this where there's solid bony fusion or ankylosis of the SI joints. So here's 4 different patients with ankylosing spondylitis, and so we see this fairly commonly. Maybe one case every couple of weeks, or we're following up the same patient. So it is something you're going to run into. They get a lot of kind of classic findings. They get like squaring of the vertebral bodies. They get these white lesions called shiny corner sign. I think sometimes called the Romanus lesion in the edges of the vertebral bodies. And then they get fusion, especially, you get fusion of these syndesmophytes along the spine here. See all this flowing ossification here, but as well as the apophyseal joints of the spine. So the facet joints get fused over time. And so what's the other main disorder where you get like this kind of ossification along the spine? Like DISH, so diffuse idiopathic skeletal hyperostosis, where the ossification in DISH tends to be a little bit more bulky and maybe scattered a little bit more than in ANKSPOND. But in DISH, you tend not to get the fusion of the facet joint, so that's a helpful differential feature. So because the spine is so stiff, and there's a lot of leverage in, the body, the weight of the body in different parts. So in people with ANKSPOND, they're at high risk for spinal injury and just kind of snap across a disc space or sometimes across a vertebral body there. So here's a couple of other examples that we've had here where actually 3 different patients here. So Angst-Spond, cervical spine fracture, kind of just below the disc space. Here's a lumbar kind of fracture malalignment here. All this is fused. Another kind of thoracolumbar region fusion here. So really dramatic injuries in these patients. So that's definitely, if you're on call looking at CTs and you think somebody has Angst-Spond, be very, very suspicious that they're going to have an injury. They're also at somewhat higher risk to get things like epidural hematomas. So that's good to know as well. This was an unfortunate woman who was, pushing, I guess, during childbirth and had ankylosing spondylitis and ended up fracturing kind of the L1 region here and had spinal cord compression based on that. Ended up being, transiently paraplegic, but after this went and got spinal fixation. And at 3 months, luckily she was able to be walking again and kind of recovered her function. So the sacroiliitis of the SI joints, erosive change and sclerosis, but the enthesitis is this type of thing where like at the Achilles insertion, you see these white areas, maybe erosions, bone marrow edema, and the plantar fascia insertion onto the calcaneus here, this white inflammatory change. Should have pointed at this first though, because this is like nice like erosive change at the Achilles insertion here and plantar fascia. So we see a lot of like plantar spurs or enthesophytes. They're usually smooth and they're innocent, benign, non-inflammatory. But if you are suspicious of an inflammatory arthropathy, you'll see more irregularity of that plantar enthesophyte, and that could definitely be seen in psoriasis or Angst-Spond or in so-called reactive arthritis, which we'll talk about in a second. More advanced ankylosing spondylitis. So here's hip involvement, severe bilateral arthropathy. It's very hard to know for sure what the etiology of this type of arthritis is. This one's even leading to what's called protrusio acetabuli here. Here's a young man with a seronegative spondyloarthropathy, which is kind of the generic term for these types of things, that has got much more advanced arthritis than you would expect in a 23-year-old, narrowing osteophyte. So this is probably the arthropathy that's primarily related to this spondyloarthropathy. So Reiter's disease, the last inflammatory thing I'll talk about, and then the latter parts won't go too long on this talk. I know it's kind of a long talk here. It's now called reactive arthritis because it turns out Reiter had a very nefarious past in I guess Nazi Germany, so they're no longer going to name a disease after somebody with that kind of a background. So reactive arthritis is the term we use. And they get arthritis, they can get conjunctivitis, urethritis, kind of a whole clinical syndrome of things, especially in young males. I think there's some discussion about whether it has sexually transmitted capabilities or risk factors as shown here. But basically, you can think of this as the same kind of arthritis that you see in psoriasis. Okay? So get conjunctivitis. That's obviously that. They can get bursal inflammation and enthesitis, like shown here, like a little bit of erosive change here, and so on. But just think of that kind of as similar to psoriatic arthritis. A little bit about crystal diseases, because this can look a lot like an inflammatory systemic arthritis, okay? So gout's the classic one, and that's from uric acid crystal depositions. It's often idiopathic, why people get that, but then there's folks that are at risk for it. If you have renal failure, if you're on myeloproliferative diseases, certain drugs will cause uric acid increases. And so the target areas for gout also kind of scattered around, a little bit like psoriasis, can involve bigger joints or like wrist, or it can involve tarsometatarsals. The classic is the first MTP joint and so-called podagra, right? So it could be mono or polyarticular. That podagra is the classic thing where even the bed sheets on the toe is so painful that people can't get by without being seen for medical attention. And so they get these acute attacks. So here's a good picture for gout. Lots of soft tissue swelling and erosions that are a little bit further away than those bare areas often, and these big kind of punched out erosions in gout. Another example of gout here with soft tissue swelling, erosion right there, shown a little bit better there. That's kind of would be considered like a marginal erosion. Now, gout is one of these things that you'll see the erosions. Let me go back to that case here, the first case. These big erosions, but notice this actual joint space is still fairly well preserved. And that's kind of a feature of gout. It tends not to like narrow the entire joint. You just see the, this erosion's eating away at the bone. And it's not until later on in advanced cases that you'll see the actual joint get narrowed. So that can help you determine, that it's gout as opposed to something like rheumatoid, or psoriasis. It tends to narrow the joint more. Some people can get, chronic gout with tophaceous deposits, and it's useful to know that those tophi can lightly calcify, so they can be a little bit more radiodense than things like rheumatoid nodules, and that may help you. They're usually not overtly calcified, but they're like faintly calcified, and they get these punched out erosions a little bit further away from the joint. So here's another example from Henry Jones. Like this is a nice representation of gout right here, where you have these erosions with so-called overhanging edges here. I thought I had a zoomed in one of that with soft tissue swelling, this kind of like these tophi. And notice that these tophi are kind of brighter white than the surrounding soft tissues, because that's because of this probably a little bit of calcification. And so here's a more densely calcified olecranon tophus. This overhanging edges bit. So this is kind of the buzzword for gout. Here I'll just go back to this bilateral hands. It's almost symmetric in this patient, extensive involvement, but these nodular areas. And we'll zoom in on a different joint here. But this overhanging edge is where you have kind of edge of bone still like projecting out like that, but then its bone's eaten away from that erosion right there. Okay, so that's a good overhanging edge. Tophi, again, another olecranon tophus, but with pretty well preserved joint otherwise. You can get gout in other joints. So here's like probably facet joint involvement, where it's actually going and having a tophus kind of inside the spinal canal. You can imagine that could be fairly symptomatic, right, if you get nerve impingement from that. See, this patient's got a little tiny dinky remainder of the right kidney, so in a chronic renal failure type patient. The other crystal disease to be aware of is CPPD, calcium pyrophosphate disease, and that tends to target like the wrist with chondrocalcinosis and the second and third MCP joints. So this is calcium pyrophosphate. It's like middle age or elderly male skin. It's not very specific. It's not uncommon to see chondrocalcinosis, but you can have like a triad of pain, chondrocalcinosis, and joint destruction that's like the CPPD arthropathy. So, and you can also get an acute onset of arthritis in a joint like a knee and have it, simulate infection. I'm not going to go into that in much more detail, but so here's like some chondrocalcinosis, some white along the hyaline cartilage of the knee here. Here's another example. Not only the hyaline cartilage along the joint, but the fibrocartilage of the meniscus can calcify as well in chondrocalcinosis. So we see this a lot, and we don't really necessarily say, oh, that's CPPD arthropathy. We just described there's chondrocalcinosis, and whether or not it's symptomatic clinically or not, or makes a difference, we don't really know. I think most often it's really not that symptomatic, or not necessarily. DIP joint arthropathy, the classic we talk about is the second and third MCP, where the people get really marked narrowing of the joints, and they can get fairly prominent kind of hook-shaped osteophytes at those second and third MCP joints. And here you see in the chondrocalcinosis in the triangular fibrocartilage. So pseudogout is this attack where you can get a big, effusion in the knee here. There's a little bit of calcification in there. Can have very, very high white count in that. So it could be definitely a mimic of infection. Okay, the last bit on connective tissue diseases we'll just buzz through here, because this is sort of arthritis, but it's also more, connective tissues in general. So lupus is one thing that you can get targeted involvement like these red dots here. And instead of getting erosions or joint space narrowing, they basically just get these like angular deformities occurring in the fingers. So this is a pretty dramatic example where there's subluxations and dislocations of multiple joints, but you don't really see direct erosions. So that's lupus arthropathy. Here's an even more advanced case where the connective tissues are just so bad, the patient's thumb is like hanging in the breeze here. The carpal bones are all shifted off to the side. I don't think we see this very often, because at least I don't have cases that are in my collection. So I think it's fairly uncommon. Scleroderma, another classic connective tissue disease where you get erosion of the fingertips, Raynaud's phenomenon, calcification, things like that. And we do see patients with this, and we'll see these scattered calcifications either right adjacent to joints or in the distal aspect of the phalanges. And so we have to kind of think, what's the differential diagnosis? Usually these people come in with a history of their skin tightness, their esophageal dysfunction, and they're kind of known to have scleroderma, and we're just getting the radiographs to see if it manifests that way as well. Some connective tissue disorders can lead to this acro-osteolysis and basically resorption of the terminal tufts. It's like this poor patient's fingers are kind of disappearing over time here. All these digits are just lost, both soft tissue and bone. Another scleroderma, lots of calcification here. And dermatomyositis, this is more in the subcutaneous region here, or sheets of calcification. I guess some of it's in muscle as well, but diffuse calcification and dermatomyositis. One last crystal thing to mention here is hydroxyapatite deposition, and I show this case just because it's a little bit of an atypical thing, but it does come up, and we've been asked to biopsy this before, and but it's not cancer. So femur here, you can barely see a calcific density here and then here. Okay, see that? It's pretty subtle. A CT was done and shows this calcification right there, a little bit of erosion into the femur there, a little irregularity. MRI shows enhancement around that dark focus. That's some inflammatory change around that calcification. And basically this is hydroxyapatite calcific tendonitis involving the gluteus maximus tendon as it comes down around to insert on the femur. It can be very painful, and because of the bony erosive changes, it's not uncommon to see that mistaken for a malignant or aggressive process. The hydroxyapatite can also do things like involve rotator cuff. We see that quite commonly, but it can actually intrude its way into the bone. So here's this dark black, that's calcium that's eaten its way into the bone here. It can cause a very intense inflammatory reaction. And here's an example from Phil Tierman. So this is other hydroxyapatite coming out of the rotator cuff into the bone, causing a really intense inflammatory reaction. And even a different manifestation where it's coming out of the tendon, it was in here, and then kind of going into the rotator cuff musculature as this dark calcification and causing extensive inflammatory change. So that's a bit of a whirlwind tour of arthritis. We talked about some of the basic features, like looking at soft tissues, joint spaces, the bone, the alignment, the distribution probably being the most important thing. And some of the pearls I wanted you to take away are that, remember, rheumatoid tends to spare the DIP joints. Psoriasis tends to, or can involve the DIP joints, but has this periostitis, enthesitis, and fusion, as well as preserved bone density. And in gout, the joint spaces tend to be preserved overall, even though you have those erosions, and the tophi are a little bit higher density than surrounding soft tissues. You can remember or try to remember these kind of little patterns of distribution where rheumatoid's fairly diffusely involved but spare the DIPs. Psoriasis leads to that sausage digit, OA kind of scattered around, gout kind of scattered around, and CPPD tending to affect the second and third MCP joints. So that's it, and thank you very much for your attention, and